There are three problems during the retained placenta. There are three problems for retained placenta. Placenta separated, but it is entrapped within the uterine cavity. Sometimes, most of the time, we found in this. It really separated, but there is inertia of the uterine wall, and placenta cannot come out. So it is entrapped and not separated, totally not separated from the uterine wall. And another is morbidly adherent placenta. It is rare, less, not rare, but less. Due to nowadays more cesarean section, more DNCs. So this is just some outline. Separated, but it is entrapped. It is also in the lower part of the uterus, it is entrapped, not coming out. Then, so here you saw how that is the control contraction for the removal of the placenta. Upper hand is in the that is suprapubic region. We push upwards and backwards like this. I showed before. We can that is control contraction means how we open the pen. If you think this is placenta and this is uterine, placenta just it is uterine cavity. So just control like this. Here this is suprapubic pressure in this, and that is what happened. So here you saw. So that is upwards and backwards, so that no uterine inversion. Here downwards, backwards and forwards like this. That is called control. Control means you do not allow the uterus to be inverted. So this is called in the upper hand suprapubic pressure, upwards and backwards, here downwards, backwards and forwards. This is the called control contraction. And then uterine massage. These are the components. Another is you see sometimes in case of retained placenta, we empty the bladder and here we push some injection oxytocin. Injection. Here injection oxytocin we push in the umbilical vein and through the umbilical vein it passes through the different chorionic villi and then there is causes uterine contraction.
To stop.
Achha.
Student assembly তে উপস্থিত ছিল এদের অ্যাটেন্ডেন্স পাবে না assembly তে যারা উপস্থিত ছিল those who are absent in the assembly counted as absent in the first class প্রথম class monitor reporting this আর তো সমস্যা নাই ঠিক আছে ম্যাডাম ডিস্টার্ব করার জন্য ঠিক আছে ওকে
The umbilical vein, through the umbilical vein, there it is that is cannulation of the umbilical vein. Cannulation of the umbilical vein and then injection of oxytocin is pushed. This is one of the management for to start uterine contraction, pushing of the injection diluted oxytocin directly to the umbilical vein. So this if we put the through the umbilical vein, diluted oxytocin goes to the different structure of the placenta and ultimately to the uterus and then it causes contraction. And after that, again trying and supra control that is like this, again giving injection oxytocin and then control contraction. This is the way, the control contraction. You never forget this, control contraction for removal of the retained placenta. Understand everyone? Okay. You should show in the auspice station how can you remove the placenta. uterine placenta. Anyway, so that is, if not possible in this way, then what we do? We do what we do? If not, then under anesthesia we remove manually removal of the placenta. We should give anesthesia as it is more painful, and then manually we remove the placenta. Suppose placenta is in the uterine cavity. This is uterus. So at first we push through the vagina and we feel the hands. This is this extensor flexor aspect. This side, smooth side at the side of the placenta. We at first form a cleavage line in between uterine wall and the placenta. That's like this, and then we put two finger and we do like this, and again, and we like this. We create more pressure. Where is my finger? In between uterus and placenta. Okay, like this separation, after we go to the fundus. And then again we try to separate all the components of the placenta from the uterine wall, and we go to the fundus, and then we do like this, and then we want to push again some oxytocin drug, and then we remove this. This is called manual removal of the placenta under general anesthesia. Okay? So this is some other extra points. Another is I want to show again just to show some points how the labor progress. And what is this? Cervix dilated or not? No dilatation. There is gradual dilatation, and you see the cervix is fully dilated, completely dilated. Okay, and then this is partograph, normal, progressive cervical dilatation like this. From 4 centimeter, we start our active phase of labor. Okay. Not there is a latent phase. I will just memorize you. What is the definition of delay? You know that is if slow. That is 1.5 centimeter per hour in the primary and 1 centimeter per hour of the multi cervical dilatation. If not like this, then it is called delay. Causes of dystocia, I already told about this. And ultimately, actually, if there is a difficult labor, what is the problem? Every possibility of the postpartum hemorrhage, every possibility of the infection, and there is ultimately following obstructed labor, there is rupture of the uterus. Okay. Secondary arrest, in the second stage of labor, that is 2 phases. That is protective phase, another is expulsive phase. There may be arrest in the any stage in the labor. So I already told everything, I hope so. You see that this is ischial spine level, 0 station. If above this, minus, that is not engaged, and these are the, this is if below crosses this is the plus station. Engagement, you see, I show you this sagittal suture, antefontanal, this is coronal suture. How it is this? Asynclitism, this is called normally this suture line should be like this. This is transverse arrest. The different position, fetal head, I already told you. What is this? This position, the brow. The different diameter of the fetal head. Subecsipitobagmatic is the normal. If away from this, it causes different abnormal position, and which cause abnormal position of the fetal head causes obstructed labor, that is abnormal labor. Hyperextended asynclitism, if the sagittal suits are not matched with the anterior posterior diameter, that is called asynclitism, like this asynclitism. So what are the next class, maybe the obstructed labor, you need to know the obstructed labor. Yesterday we faced on obstructed labor, and we do the immediate cesarean section like this. So these are some other oxytocin for augmentation, if everything is good. How can we reduce the poor progress of labor? We can reduce so many ways. At first, a proper assessment of the mother, and the maternal, sometimes mother is exhausted, so we should take care of her nutrition, hydration, educate analgesia, maintain the partogram, and like this. So partogram maintenance is so important to reduce and to diagnose earlier of the prolonged labor and the obstructed labor, and to reduce maternal and fetal complication. Okay, thanks for today. Any question? Anything? Thanks to all again.